Welcome to Deuk Spine Institute. It is December 5th, 2023. I'm Dr. Deuk Majan, CEO and founder. Our patient is from Buffalo, New York. He has several spine issues. One of them is he has severe thoracic pain in the thoracic spine. And we have investigated that pain with an MRI as well as our special x-ray, which shows that the patient has herniated degenerated discs. And they were pretty much missed by his MRI scan. Num num. We're going to get started. I first have to access the T7-T9 discs on the left side. Now, what was interesting, when we did his x-ray, it looked to me like he actually had 11 ribs. And we've just discovered today that he has a 12th rib, but it's very, very small. We call it hypoplastic. And Jordan, you want to show us that hypoplastic 12th rib? There it is. You guys see that there, Henry?
Yes, we do.
Skinny little thing that's barely noticeable. Show us the 11th rib. Now, you would expect to see that 11th rib down below, but he has a very unusual rib there. So, knowing that, show us 12, the pedicle of 12. Yes, 11. Yes, 10, 9, and 8. So our first disc is going to be 8, 9. Shot? All right. Your head. 12, 11, 10, 9, 8. So, and by the way, this is right where he mapped out his pain to be. And he's going to be awake for the first part of the surgery. 12, 11, 10, 9, 8. Everyone agree that's 8, 9? You're doing great. Lay still. Now he's got to be awake for the beginning. I need his help. All right, so I may want to start a little bit lower. You're fine. Lay still. You're doing great. Shot. And Jordan, show me. We need to move north a little bit. And you can see T7 was fractured. He does have a history of an old fracture of T7. All right. Now, I'm going to have to reorient, Jordan. Which do you think is 8, 9? You think it's above the needle or below the needle? Because I moved the needle position. Let's go back to an AP. I have a bad feeling it's above the needle because it looks like a fracture of 7 right above there. That would make that disc below the fracture 7, 8. I see. So it's 7, 8, 8, 9. You're correct. So 8, 9 would be the one below the needle. Shot? All right. So let's count again. 12, 11, 10, 9, 8. So it is below the needle, as you suggested. I may have to do, probably going to have to do separate incisions. Shot? All right, so that looks like it's over the disc that we want. 12, 11, 10, 9, 8. Everyone agree? 8, 9, 9, 8, same thing? And that's the lower disc. Once we get the lower disc isolated, so let's see if we can clean up the end plates at 8, 9. I think we need to wag it off a little bit. Just so you want to know, wagging is when we move the x-ray one side and we keep the other side fixed. Let's try a little bit more. I mean, it looks pretty good there if you look at the pedicle of 9. Oh, that's even better. I like that. I like that. What do you think, Jordan? You like it? Yeah, I think we could do a little better, but that's pretty darn good. Let's just go with that for now. Okay? Let's go with that. And you can see where we're going. It lines up with his X's. I don't mean his ex-wife or anything. That was pretty good, wasn't it? trying to figure the best spot to go in. Sometimes it's a matter of a millimeter difference. Okay? Shot. Perfect. Shot. And sometimes I have to adjust things. I think we're off on the WAG a little bit. And the orbit. We're definitely off on orbit. Let's fix the orbit. So for those of you watching for the first time, we are using an X-ray machine called a fluoroscope. Oh, that's really nice. We're using an X-ray machine called a fluoroscope. And basically, I think I need to be a little bit higher, but let's see what I can do here. Yeah, maybe it may work. No? I'm hitting on the TP, I think. Let's go AP. At least we're lined up nicely with the disc. I'm going to verify the disc once again. How's he doing, doctor? Yeah, no, not yet. We're not ready for him to wake up. I am a little bit too medial, so I can go a little more lateral, which is perfect. And there's 12, 11, 10, 9, 8. You agree? Yes, sir. Everyone agrees. All right. So it's always best if you're doing thoracic endoscopic surgery to go a little bit medial with the tip of your needle rather than too lateral. It's always good to start by touching a little too medial. Medial means closer to the facet. Shot. There we go. That's looking pretty darn good. I'm happy with that. Shot. We're making some good progress here. Shot. All right, we're coming in on our first target. Are you happy with the orbit? Let's get one more AP real quick. You can see the lung fields there versus the abdomen. That's the diaphragm, the shadow of the diaphragm, right just in front of the needle tip. Oh yeah, that's beautiful. 12, 11, 10, 9, 8. Everyone agree? 8, 9. When you're doing surgery on the spine, it's actually important that you actually treat the right level, the level you're targeting. And we always want to make sure that we are. Shot. All right. I think that's pretty good. Shot. We're right at the back of the disc. Shot. Mm-hmm. Looks like we're right there, huh? We are inside the disc. That's one down. Now we call this a transforaminal approach. You want to do the short needle?
Yeah, because if we want
Let me see the long needle.
look the line over here.
Yeah, I think you're right.
Yeah.
I think
If
we're
in that
okay.
case,
I think we're
we can
okay.
work better.
Well, no, I'm not going to go through the same incision.
No. That's what I'm saying.
Yeah, that's perfect there, Jordan. So, do we need any more num-num for the skin? Now that we know where we're going in, I'm going to give him a little bit more numbing medicine. He is awake, by the way, folks, just in twilight. That's how we want him. We need his help. I need him to give me some feedback in just a moment. See, I'm giving him a little bit of numbing medicine. Let's see the top. Just want to keep the skin nice and numbed up. Any questions from the audience?
Yes, we have a couple comments and questions. With the question, this comes from, forgive me if I'm not pronouncing the name correctly, Aous, spelled A-U-O-S.
Shot.
And they're from YouTube, and they ask, hello, Doc, is bulging discs treated the same way as a herniated disc?
Yes. Yes. Ames or Abes? Which one is it? Ames?
Aous, it's A-U-O-S.
A-U-O-S. All right. A-U-O-S. Os?
It's like Aous, Os.
All right. You're correct. A bulging disc is a herniated disc. There's no difference. Herniated disc just means a tear within the wall of the disc where the jelly has squeezed through the tear. Now, a bulge is a small herniation. There are also larger herniations that we call extrusions, for example. And you're talking about a smaller herniation called a bulge. Shot? All right, I'm lined up nicely. I may want to start just right there. Again, there's a millimeter difference, a few millimeters there. Shot? Once again, I'd like to just slip just lateral to the facet joint. Shot? He's a little bit too much. Shot? All right, let's get an AP view. Lay still, you're doing great.
Okay, my friend.
Let's go, Jordan. How are the elbows? Good? Can you guys check? Yeah, I know. But I still have about 10 minutes at least before I'm ready for him to be responding. That looks good. That looks really good. So just to remind you, this patient has a fracture, and you can actually see the fracture of T7 from some remote trauma. Jordan, show us the fracture of T7 on that AP. Henry, take a look at this AP view. Here it is. So the arrow is at the top of the bone and then go to the bottom, right there. Now that distance from top to bottom is different, dramatically different than the one below. You see that? It's got about a 10 to 15% what we call loss of height. We know he's got a fracture at T7, and we're fixing the two discs below the fracture, T7-8, 8-9. Okay, very good. I think we're off on orbit by just a tiny bit. Maybe a degree. That seems, I don't know. I don't know if that's worse or not. I would say we're off on maybe wag a little bit. But you guys can see the fracture there right in front of the needle. We're not here to fix his fracture. It's an old fracture. Lay still, you're doing great. Shot, is that my latest shot right there? It looks a little worse on orbit, to be honest with you. Let's see what we can do. You can kind of see the back of the pedicles there. Shot. I almost feel like that's even worse, Jordan. Maybe the other way. Shot. And a little more. Let's just see what a little more does. I don't know. That looks probably better, right? What do you think, Jordan? Looks a little bit more aligned. I agree. Let's leave it at that, and let's see if we can work with this. All right, Doc. You doing all right? Shot? Shot? There's the facet. Shot? Looks like we're coming in nice right onto the disc. Shot? Well, I'm a little too medial, so I'm going to pull back. Shot? Just go a little bit more lateral. I want to skive just past the facet joint. Skiving. Now we're right at the back of the disc. Yeah, you can tell it's a painful disc. He does not like that. And this is the one that was just below the fracture. You can see I'm trying to enter the disc. Well, Luis, I gotta say, that's impressive. It fits perfectly. All right. And for the last one. So, folks, so far we know that we are in 7-8, 8-9, that's the fracture of 7. We're going to go up to 6 and then 5. We're going to do 5-6, correct? Everyone agree? Jordan, are you as far north as you can go? Yeah, I understand. How's the arms? I'm going to need some help with the arms. You guys need to check the arms. I want to make sure this is not resting on his elbow. And can the fluoro drop at all? It looks like you're off on orbit, right? I think you left the orbit open and it just moved it. Shot. And shot. All right, so I see 7, 6, 5. We're doing 5, 6. I think we can get it with that, Jordan. All right, let's go to the right side. And once again, I have to access the disc first before I already put it. Yeah, we put it a while ago. It has Marcaine and lidocaine. Shot. All right, not bad. I can aim down a little bit and we should be good to go. We'll put some more num-num for Dr. Berndes. So we're fixing 3 discs today. Uh-huh.
Yeah.
Sorry. Shot. Give him a little bit of numbing medicine. Got to be careful not to numb the spinal cord, especially this high up. We don't want him having any respiratory issues. So I can't use, I just have to be careful. All right, that looks pretty good. Right around there. Shot. Very nice. Everybody agree that's the other disc we're going after, which is number 5, 6, right approach. We're on the right side. That looks good. All right, there's facet. Mm-hmm. And beautiful. Shot. Give me an AP. Any questions? This will be a good time for questions.
Yes, this next question comes from Ali on YouTube.
Hello, Allie.
They ask, I'm getting a thoracic MRI tomorrow so you can review. Insurance won't cover. Do you know, is there any downside to myself paying for the MRI that may impact insurance covering surgery for the issue later?
Yeah, it's a great question. We hear this all the time. Insurance companies are always trying to discourage patients from getting the care they need, including not covering things like MRIs that they need. I would do the MRI. If you want to get rid of your thoracic pain, in the end, get the MRI done so you can get answers. I don't think the insurance companies can deny your claim just because you got an MRI on your own. All right. So far, everything is going quite well for this patient. And we're now navigating shot just past the facets towards the last disc. Shot. I'm right at the back there. I can feel it. Shot. Oh, Lord. Wonderful. We're there. So fortunate. It's always better to be lucky than good. Isn't that what they say? So we have now accessed the 3 discs. I'm going to take a marking pen. Let's get the light on. So folks, this patient has traveled far to come to Florida for this procedure because there's nobody else in the world that offers this particular treatment. What's beautiful, and he's going to watch the video later, I marked out where his pain was before surgery. Lay still. Okay, he's just waking up. And you can see that lines up perfectly with where we're treating. Okay, that's the 2 discs. This is number T, lay still, you're doing great, 8, 9, and T7, 8. Now we had to figure out where his pain was coming from using a physical exam, special x-ray, and his MRI. And the MRI was not helpful at all. The radiologist pretty much read it as just one herniated disc and a fracture. That was it. We had to figure the other 2 out ourselves. Lay still. All right, you guys got the arms? And then this is, just lay still. Is he a bit confused or you think he's?
Can you open your eyes for me, my friend? Okay. We're gonna
Don't move.
Don't move, all right? You're doing great.
We're almost done. We're going to put you to sleep soon, okay?
You gotta give us a pain score, all right?
Just lay still. It's very important you lay still.
Big, strong.
All right, let me know when he's ready.
Are you ready, my friend?
Do you want her up there with the other arm, or are you good? All right. All right, just lay still. You're doing great. You having any pain?
Are you having any pain in your back? Yes? You said yes.
All right. Do you think he's reliable? How bad is that on a scale of 1 to 10?
Give us a number. Give us a number.
Give us a number. How high? I heard him say 10.
Huh?
How high did it go? Was that where you get pain? Is that where you typically get pain? Yes? Yeah, that's a 10. Yeah, that was I heard him say 10. So that was a 10 over 10, and it's concordant. And that was number 7-8, folks. Look at the size of the tear. Huge. You all saw I did the injection. I didn't tell him when I was injecting. He has no idea. And then he started saying, oh, oh. So we know that that disc, number 7-8, is money. That's causing pain. Hey, you're doing great. Just lay still. You okay? You okay? All right. Better? I need your help. You tell me if it hurts and how high the pain goes, okay?
Give us a number.
Oh, that thing is scarred up. Shot? Oh, yeah. That is really... How bad is that on a scale of 1 to 10? How high?
I just said 10.
10. Is that where you get your pain? So we got 10 out of 10. Is that where you get your pain? Yeah. 10 out of 10, concordant at 7, 8, 8, 9. Okay. Well, that so far we're batting 1,000. We got 2 discs that are painful. You can see the tears in them. You can see the dye leaking out. Is that better? Lay still.
Your arm's still, all right?
Now remember, he's wide awake right now. He's just got a breathing mask on. And we just need him awake for just another minute, and then we'll be ready to put him to sleep, okay? Are you comfortable? Yeah? All right, good. Are you having any pain? You having any pain?
Any pain right now, my friend? No.
No, all right. We're going to put you to sleep in just a minute, but I need your help for a little bit longer. And his disc, huh? Shot? Can't even get any stuff out. How bad is that on a scale of 1 to 10? How high? 10? Is that where you get your pain? All right, so we got 10 out of 10 at all 3 discs. You get to go to sleep now. So you can see from that last injection, I barely got any dye out because the disc is so scarred from all the years of inflammation and pain and suffering. He has a tear, he has a herniation. The herniation causes inflammation. It never stops. It lasts for years and years and years until we come in there and get rid of the piece of herniation that's causing the inflammation. That's what we're doing right now. Just lay still. You're doing great. So we got a 10 out of 10 at 5-6. We got a 10 out of 10 at 7-8, and a 10 out of 10 at 8-9. All concordant, 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 meaning that's his typical pain he gets every day. All right, so you want me to start here, Luis, bottom one? Sounds good. Just giving you some numbing medicine. Any questions?
Yes, this next question comes from Sherry on Facebook.
There's Mark in here, right?
They asked, when doing thoracic surgery, do you have to position the patient differently than with lumbar? I'm just wondering, with all the ribs and bone structures, do you elevate the rib cage to open structures better?
Yeah, Sherry, great question. The answer is with the same positioning as lumbar. Let me know when I can start, doctor. I'm going to make a 4-millimeter incision. We're going to use the small scope on him because his discs are so collapsed. So the positioning is the same, Sherry. It's no different than lumbar. When I started doing thoracics, it was about 3 years ago. Shot? And I swore I'd never do thoracics. Shot? Because they are higher risk. But I had some patients come and say they were literally in so much pain they were going to kill themselves if I didn't do the surgery because they had tried everything else. And I told the patients that. I said, listen, you can die from this surgery. You know, you can die. You can be paralyzed, die, drop lung. I went through all the risks about it. And what the patient said to me, the first one, he said, I don't care, doc. I'm going to kill myself if you don't fix my pain anyway. So at that moment, I realized how desperate some of these people really were for getting relief, and there was really no other way to fix them. And they had already tried pain pills and therapy and chiropractic and yoga and everything else you can imagine, shots, epidurals, facets, rhizotomies, everything. And this first patient I did just said, I've got to have the surgery. So I decided to go for it, and I was very concerned the first time. I was very nervous as a surgeon, even though I'm very experienced. I had 17 years of independent neurosurgical experience, you know, treating thousands and upon thousands of patients with spine surgery. And I was still very nervous. That said, the surgery went without a hitch. Patient got 100% relief of their pain. I was amazed at the results. So I did a few more, and lo and behold, we just published our data last year on the first, I think it's 20 patients that we've done, and our result is 99% pain relief at 1 year, 13 months after surgery, on average follow-up. That's the follow-up with the patients, asking them, how much of your pain do we get rid of? The answer was 99% on average. So I think we had 190% in there, the rest were hundreds. Point is, it works. Okay, we're at the back of the disc, and we're going to advance the dilator now. And I think the choice of cervical was right. You can see the patient. He's responding just a little. He's asleep, but he's wiggling. That means that we're at the right disc. This is a painful disc. No doubt about it. No, I don't want you to give him any more. Okay? I'm perfectly happy with our level of sedation. Yeah. My point is, this is a painful disc. You just touch the back of the disc, and it sets them off. All right, dilator's in. Look at this tiny incision. Look at this. This is an incredible surgery. I've been doing spine surgery for 26 years, 27 years almost. And I'm used to doing the big open surgeries with taking the muscle and ligaments off the spine. But just to be able to fix these problems in front of the spine, in front of the spinal cord, to be able to do this like this with these tiny incisions and no bleeding, virtually no pain afterwards, no narcotics, is incredible. It's an incredible advancement in spine surgery, is what we're seeing here. You guys are watching the future of spine surgery happening today at Deuk Spine Institute. All right, we're creating a tiny little channel to do the surgery. I'm putting in a tube. It's called an endoscopic tube, okay? And the purpose of this little tube is so that I can bring my laser down and guide my laser to do the surgery. I'm going to use the laser to remove the herniations, clean out the tear. I see you came prepared with your vice grips. We're prepared today. Henry, you see that?
Yes, sir.
Now, we got a couple of types of these surgical instruments. We call them vice grips because they are vice grips. You can see made by Husky. This is probably the cheapest surgical instrument I have in my entire surgery center. You know, $15 vice grip. It's funny how this amazing piece of engineering and steel costs $15, and this tube right here is over $1,000. All right, that just shows you the markup on surgical stuff. Okay, we're ready to get started. Our patient is sleeping beautifully. Dr. Berndes would say he's in the anesthetic plane. Personally, I didn't know that my anesthesiologist had a plane. Never told me about your plane. Huh? Is it a jet? Anyway, we'll take some more questions while we work at this thoracic disc, our first one today.
This next question comes from Amartos on YouTube.
Amartos, welcome back. You're at 20? You're at 20?
Nikki, 20.
Nikki, put the phone down. Don't embarrass me. Come on, we need you on. All right.
The question from Amartos on YouTube. They asked, if a doctor orders an MRI, how can insurance deny that? I never had insurance deny it for me before.
Yeah, Amartos, great question. You are correct. They should not deny it, but they do. Let me tell you why insurance companies deny everything now. Everything. Because they can get away with it, Amartos. They can get away with it. You see, the insurance companies have spent the last 40, 50 years writing our laws quietly in Congress. They have bought the politicians. They have taken them out to dinner. They've financed their campaigns for election. And they've told the politicians, we want you to write this law that we the insurance companies, don't have to pay for experimental surgery. Experimental surgery. We, the insurance companies, don't have to pay for experimental tests and treatments. Experimental tests and treatments. Pay very close attention. And the politicians said, well, yeah, that kind of makes sense. Why should you pay for anything that's experimental? Right? It's experimental. We don't know if it actually works. And the insurance company said, yes. All right. So they got this law written that they don't have to pay for anything experimental, which makes sense, right? Well, then they went and spent the next 30 years calling everything we do as doctors experimental. And they're calling it experimental. That's how they get away with not paying for the MRI. Now, you may sit there and say, but MRIs are not experimental, right? They cover them. And the answer is yes, you're right, but what they say is the indication for the MRI is experimental. In other words, MRIs are not experimental per se, but using an MRI when somebody has back pain is experimental. The only reason we'll cover an MRI is not if they have back pain, but if they have weakness in their legs. Is he doing okay?
Yep.
Good. You don't have to keep him too deep for me. I'm perfectly happy with him. I am going to stimulate him a little more soon. But right now we're kind of in the deep part of the annulus where there's not too much nerves. And I'm just removing this herniation a little bit at a time. So that's why, Amartos, insurance companies wrote the laws years ago with the politicians, unbeknownst to anybody. They secretly planted this seed. And now that seed is growing into a giant tree for them. And what they're doing is they said, we don't have to pay for experimental treatments and tests. And everybody said, yeah, that makes sense. And now they call everything we want to do experimental. That's how they get out of paying for the Deuk laser disc repair when they get out of paying. They call it experimental. So then the question is, well, when is it not experimental, right? And then you got to go to trial. You got to go to court to prove it's not experimental. Well, what doctors can afford to go to trial? Trial is a minimum of millions of dollars. So I can't, pay millions of dollars to take the insurance companies to trial to get them to agree to pay a $50,000 bill, right? So they basically created a system using our legal system against us to where they don't have to pay for anything experimental, but they get to call whatever they want experimental. In other words, we don't get to decide what's experimental, they do. Now you can challenge their definition of experimental, and our doctors do, okay? There was just a case where a trial lawyer, who wanted to have proton beam radiation therapy. He has cancer in his throat. He had cancer in his throat, and his doctor said, you need radiation therapy called proton beam radiation therapy. You need that in order to cure the cancer. And Blue Cross Blue Shield insurance said, nope, it's experimental. Well, guess what he did? He sued them. Now, he paid for the treatment first. That's the key. You got to pay for the treatment first. It makes all the difference in the world. If you pay cash, he paid $95,000 for the treatment. Cash. Okay? He's just coughing. He's doing all right? What do you think, Berndes? Huh? And he ended up paying for his surgery. Is he doing okay or what? Should I keep going? All right, just about done with this one. Then he sued Blue Cross because Blue Cross called it experimental surgery, experimental treatment, and he won. He won. And that's the key, folks. You got to fight your insurance to get what you need. Okay? That's not something I could teach you. You got to go out and learn this. But the insurance companies will say everything is experimental. Everything that you'll let them get away with. You have to fight. By the way, they used to call artificial discs experimental too. And then the companies that made the artificial disc sued them. Sued Blue Cross and won. And now you can get your artificial disc done. But it required lawsuits. Okay? That's what people need to understand. You want it, you got to fight for it. I'll help you, but ultimately you guys have to fight for it. If you need to keep them lighter, you can. Just about done here. Just lay still. You're doing great, sir. Almost done. Yep. Any more questions?
Yes, this next question comes from AUS, once more on YouTube.
Yep.
They ask, why is the patient awake in the process of locating the disc?
Because I have to make sure that the disc is painful, so we get the source of the pain. And I also want to verify that I'm not hurting the patient, hitting a nerve or the spinal cord. The patient will tell me if I do. So I need them awake. They're guiding me. You know? You need the patient's input. Looking good, just about done. A lot of inflammatory tissue here. You can see it. A lot of inflammation. You guys see all that?
Yes, we do.
All right.
We have another question.
Sure.
This question comes from Roscoe on YouTube. And Roscoe asks, are you able to repair an annular tear without using a laser? The reason I ask is because the insurance companies will not cover a laser.
Yeah, how convenient, right, Roscoe? That they won't cover the one thing needed to repair the tear. You cannot repair a tear without the laser. It's not possible. There is no other tool in the world that will do this. Oh. By the way, Roscoe, the insurance companies will cover a laser. They just tell you they won't cover a laser. Roscoe, I want you to remember back to elementary school when you had a bully who used to tell you you can't go to lunch unless you give him $1. Now, maybe you believe the bully, but I didn't. I ended up fighting the bully and winning. And the bully stopped bullying. Okay? And that's kind of what I do now as a person who's an advocate for patients. I don't do what the insurance companies tell me to do because what they want me to do is hurting people, and I'm not going to hurt my patients. I'm going to do what's best for the patient. So I don't believe the insurance companies. They're liars. They are absolute 100% liars, and they are lying to you. So what you got to do, Roscoe, like everybody else, pay for your surgery, get it done, and then let's meet them in court. Let the court decide if they've been truthful or not. Guess what's going to happen? They're going to melt away. You ever see The Wizard of Oz?
You think he could be having a little diaphragmatic
I'll be honest with you, I don't know if we could have some diaphragmatic irritation or not. All I know is I'm
Just thinking.
pretty much done here. Here's something. Do you? It was weird. It was kind of like a helicopter. All right. We're done here. Let me just get this last side. Roscoe, fight your insurance company. Don't let them steal your happiness and joy in life. Don't let them dictate your health. They're charlatans. You know why they don't want to pay for laser? Because it works. And they know that everybody will want this surgery. The moment we win, they're going to have to pay for it for everyone. And that's really what we're looking for, is that day that we win. And then everybody can have it. But I can't fight them alone. I need you people out there to get your surgeries done and to stand with me in court and tell the insurance company how well you're doing. All right, that's it. Great questions, by the way, from everybody. Thank you. One down, two more to go. Keep the questions coming, huh? Yeah, I don't think we're doing anything. We're inside the disc. We're in the back of the spine. I don't think we're anywhere near the phrenic nerve or anything like that. What a lot of people don't understand, Roscoe, is I've spent the last 17 years coming up with the very best plan to beat the insurance companies and make them pay for these surgeries. I've tried so many other ways and they don't work. This is it. This is the only way that it works. Shot? And the thing about it is if we win, there's no guarantee we're going to win. But if we win, it will open this procedure up to anybody that needs it. And it will be covered consistently, without denial. And it will be covered under their normal contracts, which is what we want. We want it to be covered under contract. Shot? Because if it's not covered under contracts, then we have to fight because we don't have a contract. So to get it covered under contracts, we have to have enough patients that have had it done that we can take it to the insurance companies and say, you guys owe it to your beneficiaries. You have an agreement to provide them this care, and you've basically not done your job of managing their benefits properly. That's really the only way we can have a chance at getting this procedure consistently covered by insurance like other procedures are. But you can see how they are, these insurance companies. They want to get out of pain. Shot? And they'll do everything in their power to get out of pain. Shot? All right. Right now I'm bringing the dilator down to the next level, which is number 7-8. Thank you, Nikki. What would I do without you? I would be miserable. All right. Now let me think here. I feel like I'm stuck on the facet. I'm going to have to advance this with the mallet because I can't get it advanced with my finger. Shot? I'm really close. Louise thinks I'm a magician. Stop moving it. You're moving the guide wire. Shot. That should have done it. There we go. Uh-huh. Very nice. Hold on. Take that, please. All right, let's see where we are.
Yeah?
Yep. We're right at the back of that disc. That is beautiful. I gotta say, folks, when I grew up, I helped my father hammer nails, screw things in. My grandfather, same thing. It's giving me that action, you know? It's all in the wrist when it comes to a hammer. Did you guys know that? So many people are like this, you know? That's the wrong way to hammer. You gotta have it in the wrist, right?
You gotta feel the nail.
Yeah. Gotta feel it. Be one with the nail. All right, any other questions, Henry? About my limp-wristed technique?
I don't believe it for that, but we do have a question from Khalid on YouTube.
Uh-huh.
And they asked, how much it costs to pay from your pocket in Roscoe's case?
In what case?
In Roscoe's case.
Oh, Roscoe. Well, I don't know the cost, folks. I'll be honest, though. It depends on, are we fixing one disc? Are we fixing 2 discs? Are we fixing 3 discs? Are we fixing, you know, lumbar, cervical, thoracic? Are we doing a combination? I know that all those things weigh in onto what the cost will be. Are we going on left side, right side, both sides? So the cost really is depending on what you're having done. And I would never recommend a treatment to anybody without first looking at them, you know, physical exam, and looking at their MRI. So without knowing the actual treatment you're going to get, we can't give you a cost. And without an MRI and a Zoom meeting, we can't give you a treatment. Does that make sense? So the cost depends on what's being treated and how it's treated, and the treatment depends on what we see on your exam. All right, starting our second disc, number 7-8, correct? Left side on this patient who's traveled from New York to Florida, here to Deuk Spine for his Deuk laser disc repair. All right, let's go fix this next disc. The first one went perfect. Here we go. Let's see what we can do here. By the way, I checked on our last patient. Oh, you guys didn't get to see that surgery. You guys did, but the viewers did not. He was a cervical Deuk laser disc repair, cervical Deuk plasma rhizotomy. He had fusion done in the past elsewhere. He came to us with horrible neck pain that is coming from his facet joints, right? We talk about don't get fusions because it destroys the joints above and below your fusion. And that's what happened to him. He had a cervical fusion. It was done in another place, not by me. And he came to me with horrible pain. They couldn't figure out what was wrong. We realized it was his facet joints. We did his Deuk plasma rhizotomy on his facets, and he's doing great. Is he left yet? Uh-huh. He should be ready to go. He's gone? Nice. Good job. Great nurses. Got the best nurses I've ever had. Except for, I'm just kidding. All their ears are perked up. They're like, who is he going to say? No, I honestly have the best damn nurses. I've worked in hospitals all over. Some of the best hospitals, some of the worst hospitals. Oh, did I ever tell you about my patient at Wusthof Rockledge when I first started? When I first started neurosurgery here in Brevard County on the Space Coast of Florida, I was hired by 2 hospitals. One was Parrish Medical Center, the other was Wusthof. The problem was Parrish was wonderful. They really took it serious. They hired a neurosurgeon. I told them, you got to buy all this equipment, right? All this really good equipment that I needed. They took it serious. They hired the staff. They trained the staff to do neurosurgery. because they had never really had neurosurgery. And they let me build the program. I mean, I spent $2 to $3 million on the equipment and the staff. Wusthof, on the other hand, they weren't interested in spending a dime. So they had really just, honestly, really old equipment that was outdated and broken. So when I went there to do my first brain surgery on a patient who was dying of a bleed, I couldn't even open their head up. They had a giggly saw, which is basically it's a piece of steel, like a steel wire or cable, and you have to make a hole in the skull using literally a hand drill, okay? And we don't do that in neurosurgery. We use power drills, okay? We haven't used hand drills in well, when I got there, it was in 2004, 20 years ago. I hadn't used a hand drill in there was 30 years in neurosurgery. So I had to use a hand drill, and then I had to feed this wire, giggly saw wire, under from one burr hole to the next, literally like they've been doing since the 40s.
That's how they cut scriptoplasty.
Yeah, that's right. It was the most horrible experience in my life. Because here's this patient dying from a blood clot that's killing him, herniating him, and I can't get the skull open. It was bad. And they promised me they would have all the stuff I needed when I took the job. Anyway, I was very unhappy about that. I talked to the nurse, the head nurse. They promised me the next time I came they would have everything I needed. Of course, that never happened. But I had taken another patient to the hospital and did a PCDF, posterior cervical decompression and fusion. And the patient, when you do that surgery, it's very painful. Like the first few weeks, the patients are in horrible pain with a posterior cervical fusion. So I wrote the patients for Valium, 10 milligram oral, by mouth, right? And I had the patient on the floor. Well, the nurse at night, I came in the morning to see the patient, check on him, and there's all this chaos going on, literally like 50 doctors running around, nurses running around. I'm like, oh my God, what happened? They said, oh, we had a code. I said, geez. So I go towards my patient's room and I notice all the doctors and nurses are coming out of my patient's room. I'm like, wait, what happened? That's my patient's room. And they said, yeah, your patient coded.
They gave an IV.
They gave 10 milligrams of Valium IV,
Yep.
push,
I told you, IV.
on the floor. I mean, unbelievable.
To a neurosurgeon patient.
Yeah. For people out there, that's equal to giving a 6-year-old child an AR-15 fully loaded with the safety off and saying, go out and have some fun. A 6-year-old who's never played with a gun before. You never give IV Valium to a patient 10 milligrams, maybe half a milligram, and that's in the ICU where they have, full support for ventilation. This patient stopped breathing, almost died. Anyway, that just gives you an idea of just how sometimes bad nursing can be. That's my most stark example. So I've got very good nurses. Very happy. And patients love them. We get a lot of compliments about our nurses. I got about 5 minutes left on this disc, and then I'll move to the last one. All right, any questions?
Yes, this next question comes from Ayus, once more on YouTube.
Sure.
They asked, Doctor, what is the best practice to save your back if you drive for a long time?
Drive for a long time. Interesting. Well, I'll be honest with you, Abe. So the problem is when you're sitting down, it puts a lot of pressure on your discs in your lower back. As a matter of fact, sitting puts 2.5 times, 2.5 times more pressure on your discs in your lower back than standing does. So that's why people who sit down, oh, by the way, if you're seeing this disc move, that's his breathing. You guys see that? He just took a breath in. So look at that. Since we're talking about pressure in the disc, you can see how breathing affects the discs, even coughing. And when people cough, it puts pressure on the disc. Watch, it's going to move out and in. Inhale, exhale. It almost looks like the disc is breathing, doesn't it? Pretty cool, huh? Anyway. It's called respiratory variation in intradiscal pressure. So sitting also puts a lot of pressure, just like this breathing you're seeing right here. Sitting puts a lot of pressure. The best thing to do is probably to get up and stretch your legs every once in a while. That's what I would recommend. But you see how badly damaged this disc is. Let's have the grabber. Any other questions for us? We got one more disc to go. I'm almost done here. Just got a few more minutes.
No current questions, but we do have a comment from Kane's 25 telling,
Too firm.
he's saying, tell us more stories.
More stories. I love it.
Oh, he just asked, what was your hardest case ever?
Hardest case ever. Well, you left it as an open question, so I'll leave it. I'll answer it as my hardest case ever. It was a young girl in college at University of Florida who began having headaches and developed a rash. And she was infected with a very bad bacteria called Neisseria meningitis. And she had meningitis. And the problem was nobody diagnosed her fast enough. And they didn't give her the life-saving antibiotic she needed right away, ceftriaxone. If she would have gotten that ceftriaxone right away, that third-generation cephalosporin, it would have killed that bacteria and she'd still be alive. So when she came to us, we were called, I was on plastic surgery, and they called the plastic surgeons because the problem with Neisseria is that it causes blood clots to form in your veins and arteries. And her arteries clotted off in her leg. So her leg went cold, we call it. She was only 16, 17 years old, something like that. She's a freshman. And we had to amputate her leg. At first it was a below the knee amputation because it was just distal that was dying. And then by the time we got her in the operating room, started prepping her, it was above the knee amputation because the clot spread. And pretty soon it was her other leg went pulseless. So we had to amputate 2 legs. By the time we prepped the other leg, her arm went pulseless. And then her other arm. And literally we had to do all 4 amputation. And then she just died before we could do it. That was the hardest case I've ever done. That girl died when she could have been saved if somebody had just given her the antibiotic when she came in right away. It's so sad. Misdiagnosis. Misdiagnosis. And it all happens so damn fast. Yeah, that's something you never forget.
This one's what done? This one's
What's that?
5 minutes here?
2 minutes on this one. Just about done. Yeah. That was the hardest I've ever done. Technically hardest? I don't know. I've had some pretty tough spine surgeries. Some very deep spines way down in there in the hole. Back when I was doing fusions, laminectomy, I have to, honestly, sometimes we joke around, put a rope around my ankle in case I fall in. That's how deep we would be, right, Luis? Or I'd see little yellow people down at the bottom. All right. I think that should be about it. You can see the walls of the vertebral end plates, both sides. A little bit of loose connective tissue outside the disc there. I don't really see anything more. I think we got it. Little inflammatory right there. Just hit that with the laser. By the way, there is no other tool in the world that works besides the laser. I was asked that question earlier. I just want to reiterate that. That would be like me telling you to build a house without any tools. With air conditioning and power. Right? It's impossible. I mean, nowadays they have these machines that print homes, but you can't get the electric and stuff in without tools. So when the insurance companies say, yeah, sure, we'll do surgery, but not with the laser, what they're telling you is they don't want to do your surgery. They don't want to pay for your surgery. We're right at the outside here.
Give him a little more, just a second. There's
Uh-huh.
a little sensitive.
No problem. You want me to wait?
Yes.
All right. No problem.
I don't want to start over.
Yep. No problem.
Lose the plane.
Uh-huh. We don't want to lose the plane. All right. We ready for the last one then? There's the outside. I just got one more area to hit, and we're done. Let me know when you have the green light. Any more questions while I'm waiting? You can see a little bit of epidural veins, a little epidural fat. Yes? And that's it right there.
Yes, these next two questions come from Canes25 once more on YouTube. First question they asked is, what was your first DLDR experience like?
Pains 25, I'll tell you on one condition. You write the history of Deuk's spine. All right, we're done. It was horrifying, terrifying. It was nerve-wracking. I mean, I could use many different adjectives. They all mean the same thing. I was scared to death. My first one that I watched, I felt that way, and the first one I actually did myself, I was mortified. I was doing something I had never been trained, in my residency to do, which, is okay. Doctors learn new things after they've done graduating. That's okay. But it was, you have somebody's life in your hands and they trust you and you don't want to have a complication. I don't, at least. It means a lot to me not to. That's my personal integrity. A lot of doctors don't care if they have complications or not. But for me, I don't want complications. I don't like complications. I don't have complications. And I was doing something new that there was a high risk of complications. Let's face it, you're doing a new surgery. That said, it was a lumbar. I did it in the lower back. It's safer than a cervical. But boy, you talk about pucker factor when I did my first cervical. It was unbelievable. I still remember it. We did it in a tiny little operating room in my old practice, a small building. Just down the road, as a matter of fact. We had converted 2 exam rooms into an operating room. And in Florida, you're allowed to do anesthesia in a clinic. It's called what is it called? Office-based surgery. And a lot of plastic surgeons use that to do their surgery. So that's what we did. Deuk Spine's surgical stuff started in an office-based surgery center, licensed, of course, accredited. I would never do anything that wasn't legal or licensed. And we had an anesthesiologist, Dr. Todd Rappaport, good guy. We had a small anesthesia machine. And we would vent the gas outside the window. We would crack the window and we vent the gas outside the window. How do you like that, Bernadette? Huh? And we had a little Sears generator outside just in case we lost power, because you had to have that.
The name of that scavenger system was the neighborhood.
The neighborhood scavenger, right? We used to catch, teenage kids sitting outside the window, never could figure out why they were out there. No, I'm just kidding on that. But that's what we did, folks. It was, let's just say touch and go. But pretty soon I realized how safe the surgery was and how quick patients recovered. And they needed to, because we weren't in a hospital. All right, shot. That's it right there.
Yes, sir.
We're at the last disc. Here we're going to do number 5-6. Thank you, Nikki, for not making me have to look. Shot. Our patient doing well, doctor? Take the guide wire out. All right. Beautiful. Everyone's done such a good job today. But, yeah. It was, what an experience, huh? There's no going back. And I'm so thankful that I took the risk, that my patients took the risk, that my wife told me to go learn endoscopic surgery, because she was right, and I'm glad I did. I'm really glad I did. It wasn't easy to learn. They weren't teaching it down the street. I had to go to learn from the Koreans and a German, and eventually I spent some time in Phoenix with Dr. Young, Anthony Young. He taught me a lot. I just had a nice call with Dr. Chol Kim out of California. He and I trained together with Dr. Young and Dr. Mork, Tony Mork, some of you have heard of. But we all sort of do our own thing, but we all had Dr. Young as one of our teachers. There were many more that came through. Some of them stayed with him, some went out back to their practices. I went back to Florida, obviously. I used to fly out to Phoenix and do a weekend course with him. He was the master. I call him the Yoda of endoscopic spine surgery. He's the Yoda. I'm more like an Obi-Wan or a Luke Skywalker. The young generation, not the first generation, but the later generation. Okay, last one. Here we go. Look at all the inflammatory tissue, the red, pink stuff. That shouldn't be there. A lot of scar tissue. So let's get this done. Any more questions from the audience?
Yes, this next question comes from Canes25, once more on YouTube, asking, was the other day when you discovered those inflammatory sausages one of your proudest moments?
Yeah, yeah, you remember that. That was amazing. I had Sanjay send me those. He did. I've got a whole bunch of the sausages, the granulation tissue. That was incredible. I mean, we see it all the time, right? But it usually is just faint. It's light. You don't see it that well. Those things were like major sausages. Yeah, it was a really good day for us to find those. And the thing about it is the picture's worth 1,000 words, okay? And that's true for medicine too. If you could show doctors or people what you're seeing and what it means, it goes a long way to just compared to just writing text, Visual aids, like they say, a picture paints 1,000 words, It's like proof. If you see it, it happened, you know what I mean? And I know nowadays that's not good because you got AI and all this fake pictures that aren't real. But that was on a live stream. It's the real deal. And the nice thing is I have it now forever. And I've got a bunch of other ones too, by the way. There's a piece of herniation there. I've got like a collection of these granulation tissue pictures that I'm going to put into my presentations and my books and my papers and, reference them. Because after all, that is why we're here in this surgery, for example. We're here to get rid of his thoracic pain. And that's the key to getting rid of it, is getting rid of that inflammation and the herniation. So thanks for asking. Yeah, that was great. You're going to see that on our new website. I can guarantee you that.
This next one is, I think, comment and or seeking for advice. This name is Cosmic Knight on
Hello,
YouTube.
Cosmic Knight. Welcome back.
They asked, Dr. Deuk, recent CT scan says mild end plate osteophyte and anteriorly at the C5-C6 level. Quote, I gave you the wrong measurements of possible schwannoma. It's 9 millimeter by 9 millimeter, not centimeter.
Oh, well, yeah, I was going to say a 9 centimeter schwannoma. I'm surprised nobody's told you to get that out. You can die from that. So 9 millimeter by 9 millimeter, you probably want to consider radiosurgery. And I don't do that kind of radiosurgery. Of course I can, but I don't because I'm not the best. I would recommend the University of Florida in Gainesville, for example. And the nice thing about it is if you get that thing zapped with radiosurgery, you probably will not have a deficit like weakness of your face or loss of hearing with that type of procedure, with the tumor being that small. And you could probably get lifetime, hopefully lifetime suppression of growth where it doesn't get any bigger. That would be the ideal situation.
5 minutes?
Yeah, less than 5. The problem is, 5 minutes. The problem is with tumors, folks, they always grow. Okay, it's just a matter of time. And you can have what's called a malignant transformation where that schwannoma is going to turn into some very aggressive. There'll be like a little area of it that converts into an aggressive tumor that you have to get it out. So I would go and consult with a radiosurgeon that specializes in acoustic neuromas just to get their opinion. I definitely would not have surgery for it, like open surgery like we used to do. And I've done many of those too. But I would not do the open surgery. I would do the radiosurgery only, personally, if that was mine. What was the other question about? Oh, the osteophyte. Yeah, the osteophyte in the front of the spine is not a problem. They don't do anything. Do not let anyone operate on an osteophyte in front of your cervical spine. It's not necessary. Very common problem. It doesn't do anything, doesn't cause symptoms. Just leave it alone. All right. We're almost done. This is the T5-6, T as in thoracic, 5-6. And we've already finished 2 discs. This will be our 3rd one. And you can see how damaged everything is inside the disc. These are not normal discs. And by the way, most of what I'm seeing is old, degenerative type of problem rather than fresh herniation. I don't see any fresh herniation. All this stuff right here, the waxy looking stuff, is scar tissue. This has been around for 10 years, maybe 20 years or longer. This gold stuff that you're seeing, calcium, that only comes around after at least 5 years usually. You don't get that before 5 years. So we know this is an old injury to this disc. Remember, he has a fracture at T7, just 2 vertebrae down. It's old, so he's had some trauma in his lifetime. And I always say this, herniated disc, degenerated disc always come from trauma, some type of trauma. This is going to be our last surgery for today. And Henry, why don't you play for our audience the video of how does a herniated disc, and by all means use the lumbar one, how do they cause so much pain? Why do they cause so much pain? All right, welcome back. Now you understand why these herniated discs cause so much pain. It's inflammation, folks. The tear gets that wad of nuclear material stuck in it, and then it just goes into inflammatory, massive inflammation. And we've talked about inflammation before. You all know what it is. If you've ever had a pimple on your body, hey, you guys know what appendicitis is? Appendicitis is inflammation of your appendix. Think about how painful that is. How about gastritis? How about colitis? All of those itises are inflammation, right? Even arthritis, if you want to say it, that's inflammation. So that's what we've got. We've got that inflammation going on inside his disc and other people's with a tear. That's why it hurts so bad. It's all inflammatory. So what's the best treatment? Well, this is the best treatment. You're watching it right now. Go in there and clean out the inflammation, clean out the herniation. It's called an annular debridement. We're the first to do it in the world. We're the first to publish it. It's already in the medical literature. We've published this procedure now over 10 times. And I just submitted another article for publication to the Southern Neurosurgical Society. The meeting is in February, and hopefully they'll accept my papers. Well, I only did 200 patients, but I want 500. I'm going to try to submit to Lancet. All right, any other questions for now? If you do have them, type them up. I'll be happy to answer them, but I'm about 30 seconds away from being done.
What were you gonna say?
This patient did very well. Henry, we got a few, Henry?
If that's what it was.
Yes, we have a couple of questions.
I'll come over there and answer them.
No worries.
So why don't you show our audience in these last few moments how the Deuk laser disc repair works? All right, welcome back. You see now how the Deuk laser disc repair works. Now we fixed 3 discs today, 1, 2, and here's number 3. 2 of them were on the left because his symptoms were more on the left side for the bottom 2. Number 8, 9, 9, 10, was it? 8, 9, 9, 10? No, 7, 8, 8, 9. Sorry, 7, 8, 8, 9. And then for the top one, the symptoms were more on the right side. Here's your incision, folks. Take a look at that. And there's your ruler. Can you guys see this?
Yes, we can.
You're talking about half a centimeter, 5 millimeters, the whole surgery. 3 little cuts. And he's going to go home in an hour. When I say home, I mean back to his hotel. But his surgery's over. Y'all did great. I'll come and answer your questions. Henry, if you don't mind running a nice testimonial, one of our patients that had this done. I'll be right there.
We're here at the Deuk Spine Institute. I have a patient who traveled from Ohio to Deuk Spine Institute for his lower back. And he's been through a lot of treatments in the past that didn't really work. They may have given him some temporary results. I'll let him tell you more about that. But he's here today, a new man, just 24 hours after his outpatient surgery. He had the Deuk laser disc repair. You can see in the video we made some small cuts on his back, went in through a natural opening in the spine called the neuroforamen. We didn't do any damage under the skin, and we were able to repair the herniations that have been plaguing him now for years. How long have you had problems with your back?
Since approximately 2009, quite a while.
All right, so about, what, 14 years now?
Yeah.
And you've had surgery before. How were those other surgeries?
I had 2 minor surgeries. One lasted for about, relieved my pains for 3 years. Second one, maybe 6 or 7, somewhat of the pain, enough to get me through. Over the last couple of years, the loss of balance, which really affected my job, was just getting worse and worse and worse. I really didn't know what to do. And I went through 3 local surgeons, and everybody, the only answer was fusion, fusion, fusion. That was pretty much going to end my career. So
Yeah.
I found this guy.
And you had surgery yesterday. How are you feeling today?
Just a little bit of soreness in my back. The balance is back. I know I'm on a way to recovery.
You look a little teared up there. Yeah? It's been a journey, hasn't it?
As soon as I did the video conference with you, sort of broke down like this too. So hoping
I understand.
they'd be back.
So can you tell a difference at this point now that you've had the surgery?
Oh yeah.
Yeah?
Yeah.
You said you got up and you walked straight this
That's,
morning.
I haven't been able to do that for over a year without falling. I couldn't walk down a hallway without
Yeah.
grabbing the walls.
And the reason for that, your nerves were getting pinched pretty bad. And we went in there and unpinched them during your surgery with the laser. And we did not have to do a fusion, and you're not going to need a fusion. That's the great news.
Yes, it is.
And is there anything else you want to tell your fans out there?
I just hope more people that these doctors are only giving them that option, fusion. Come see this guy and don't ruin your life.
When do you head back?
Sunday.
Sunday. You're going to enjoy Orlando for a little
I'm
longer?
gonna try, yep.
Yeah? All right. We'll try to make it out to the Space Coast and go see the rockets over at the Kennedy Space Center. It's pretty cool over there.
Okay.
All right, sir.
Thank you, sir.
You're welcome. My pleasure. Let's get you guys out of here. Come on.
Here. Okay, I hope you enjoyed that surgery as much as I did. That was a thoracic Deuk laser disc repair. And for those of you who are not familiar with our technique, I'm looking for the appropriate model. So, pardon me. Ignore the rods and screws. The spine, your spine has really 4 parts, but we kind of ignore the bottom part, the sacrum. Nobody really pays much attention. It doesn't do much. So all the problems of the spine are primarily in the lower back or lumbar region, and then of course there's the cervical or neck, which is the second most common. Wow, what a difference in the size though, huh, of those bones and the discs. Much smaller, much bigger. Why? Because your lower back carries more weight, right? So your bones are going to be bigger, your discs are going to be bigger because there's more weight down there from your upper body. Whereas your neck just carries the weight of your skull, plus your arms, whatever you're holding. So your lower back carries skull, arms, chest, torso, all your organs and your intestines, all attached to the spine right here. So your bones are bigger. That said, there's an area of the spine in between the neck and the back, the lower back, called the thoracic. And that's where you got the ribs coming in. And that part of your spine doesn't get problems very often. But we do see herniated discs, like this patient. Not just herniated, but over time they become degenerated. Herniated becomes degenerated over time. So there's an initial injury, you get an annular tear, you get a bulge, then you get a herniation, which is, bulge is really a herniation. And then over time, the inflammation destroys the disc and the disc collapses. And it just creates pain, and that inflammation and pain can last absolutely for years. And that's what happened with this patient. He's had many years of thoracic pain. He had 2 spots. There was the upper spot and there was the lower spot. And when he came out here, I used a special x-ray. I put some paper clips where he has his pain up there and down here. And we found that there were, right, 2 areas, but really 3 spots. So 1, 2, and then 3. So this is what the paper clips look like. And they lined up exactly with these discs that we just fixed today. It's silly, I'm laughing because all the high-tech equipment we have in neurosurgery, we have the most high-tech equipment in the world in neurosurgery, and I'm using paper clips and a chest x-ray to diagnose the pain. And it works. It's incredible. Just this old-fashioned technology, you know, paper clips and an x-ray, when all these other doctors at the Mayo Clinic and the, you know, whatever, the Rothman Clinic and blah, 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 you know, they're all using robots and navigation systems and multi-million, $5, $10, $15, $20 million operating rooms. Here we are operating out of our freaking garage, basically, and we're doing things that they can't even dream about doing. And that's what I enjoy the most about what I do. It brings me to work every day, is just laughing at the people that think they're so great that really suck and are, you know, basically trailblazing, and knowing that someday everybody's going to be doing what we're doing. It's just a matter of time. Well, it was an enjoyable surgery, and thank God it went well. There was no complications. The biggest thing I worry about, obviously, we're next to the spinal cord, like literally millimeters away from the spinal cord, so no spinal cord injury and no lungs that drop. So we call that a pneumothorax. That would be bad. Never had one, and everything went really well. I was also very pleased when I did the discogram, and you know, you saw he grunted in pain, which tells me I hit the target, right? We're right on target with those discs, because you never really know, right? You're using an x-ray and a paper clip, and in the end, your goal is to get rid of the pain that this patient's had for years. And so even me, you know, I'm being honest with you, I sit there and go, am I right? You know, because if you look at the MRI, there's no big herniation there. Literally, there's a fracture T7, and it's old, like 20 years old, 30 years old. And then you're looking at these discs and you're going, those are not normal discs, but lots of people have abnormal discs. Why should these be painful? And yet they are. And so when you get in there and you do the discogram and the patient has that 10 out of 10 concordant pain, you're like, yes, we hit the target. So we'll take questions.
Yes.
Yeah.
The first one comes from Teak on YouTube.
Hello, Teak. Welcome.
They said, hello, Duke Spine. Dr. Duke, what do other surgeons say to you when you give a talk? Do you have any peers who have interest in this procedure?
Yeah, great question, Teak. I just gave a talk last week, right, to the Moroccan neurosurgeons, all the spine surgeons in Morocco. For those of you who don't know where Morocco is, it's North Africa. I think it's next to Libya, maybe, or where am I thinking of? No, Tunisia. Anyway, it's a North African country, and I spoke to them. They invited me to talk about the Deuk laser disc repair. I can tell you what they said. They had a lot of questions. I gave the talk for 45 minutes. They loved it. I gave it on cervical and thoracic Deuk laser disc repair. They were blown away. I mean, I had every single doctor asking questions. I must have fielded 20 or 30 questions. As a matter of fact, the question and answer session was 45 minutes long. I thought, you know, maybe 5 or 10 minutes of questions, but they just kept asking questions. So they were fascinated with this technology. They'd never seen it before. And, you know, Morocco is not a rich country. They don't have a lot of money. The king and the kingdom support a lot of the activities on medicine and trying to develop the country's medical program. So I was very happy to try to teach them. The first thing they asked me was, how do we come out there and learn how to do what you're doing? So that was a nice compliment. The president of the Moroccan Spine Society, he was very pleased with the talk, and you could tell it was very well received. So how do other surgeons feel about it? It's a complicated question. And the truth is, it just depends on what the motivation of that surgeon is. If it's a spine surgeon who wants to do what's best for their patients and is in medicine for the right reason, to do the very best they can to help their patients get well, they will accept the talk, they will accept the idea, and they will try to emulate it in what they do. But unfortunately, most spine surgeons are not that way. Most neurosurgeons, for example, they don't even treat pain. They treat brain tumors, aneurysms, AVMs. You know, treating spine pain is not sexy in neurosurgery. Treating pain is relegated in neurosurgery to basically, I guess you could call them the black sheeps. I don't know if that's politically correct anymore, but it's basically for the neurosurgeons that how do you say this? They're just not really looked upon as the leaders in the fields. Okay? They're kind of considered the tail end of neurosurgery. So the sad thing is that pain is so important to people, and back pain and neck pain is so prevalent. So maybe I could understand their feelings about lack of interest and support of this, because if there were only like 10 people a year that had back pain. But the reality is back pain is the biggest problem, neurosurgical problem we have worldwide. There are more people with back and neck pain by far than there are people with aneurysms in their brain or tumors, or kids with, you know, hydrocephalus, for example. So if you look at all the things neurosurgeons treat, the most common thing that we treat by far is back and neck pain. And yet neurosurgeons don't treat it. Why? Simply because they don't think they know how to treat it. They don't know how to treat it. They don't know how to fix it. So they send their patients to pain management doctors. And they say, go to a pain management doctor. We don't treat pain. So this happens all the time. So what do neurosurgeons treat in the spine? They treat pinched nerves. Pinched nerves don't cause back pain or neck pain. They cause arm and leg weakness, numbness, and tingling. So when you ask me how do the surgeons react to what we're doing, most of them have no clue what we're doing and why we do it. They're like 95% of them are clueless. They don't read my papers. They don't go to my talks. They don't pay any attention. But the ones that do, they think it's fascinating, but that's where it ends. Like, they don't know how to do the surgery. They don't know how to get paid for it. They don't know where to get the equipment. They don't know how to set it up. It's like overwhelming for them. They're just blown away, and they don't even know where to start. It would be like me taking a stealth bomber over to Morocco and showing it to a camel herder and saying, build this. They'd be like, I heard camels. I know where the hay is, where the water is. I mean, that's about it. I don't know how to build a stealth bomber. It's so technologically advanced for them, they don't even know where to begin. Like, forget about just finding where to buy the tools and equipment, because it's all new stuff, but they don't even know what to do with it, right? They have to be trained. So I just think for the ones that actually do care, they're overwhelmed. And for the vast majority, 95%, they don't even know about it. They have no interest in it. They're busy doing fusions and other stuff. Yeah. So it's a complicated answer to a very good question, but that's the best I can do.
This next question comes from Yin Yang Yu on YouTube.
Yin Yang Yu, yes.
They ask, could the osteophyte irritate a nerve?
Can the osteophyte irritate a nerve? No, they never do. It's funny because if you look at where the osteophytes are, they're close to the nerves, but they never really do any damage to the nerves. If I were to take 100 people with a herniated disc in their neck that had a pinched nerve, probably 10% of them would have a big osteophyte that even came close to the nerve. And even if you left that osteophyte, the patient would do fine. The number of osteophytes you need to take out to get rid of the symptoms in the patient is maybe 1 in 100. It's rare. We used to believe that you had to take all the osteophytes out. I used to believe the same thing. I would tell the patient, you got a bone spur. We got to go drill it down and fuse your spine. But then when I started doing the laser surgeries and the patients didn't want me to drill the bone spur, they said just do the laser, and I did the laser surgery, and then they woke up and all their symptoms were gone. After like a few hundred of those, you're like, maybe we really don't need to take the osteophytes out. We've been telling these people the wrong thing all these years. See, I'm there. I've been there for years, but other neurosurgeons are not there. And I don't know why they're not there. I don't know if they're not there because they know they're lying to the patients, or do they really believe what they've been told, that they have to take the osteophytes out? I don't know. I mean, does it really matter in the end? The truth is, you're the patient. You've got to do what's best for you. Do you really want to go to a surgeon who's going to be trying to scrape and drill osteophytes off your spine when they don't need to come off? Or worse yet, leaving them there, you know, and not even taking them out? For me, I wouldn't do the invasive surgery. I would do the laser surgery every time.
Next question comes from Kings25, once more on YouTube, asking, do you find that thoracic herniated discs are more calcified?
Do I find that thoracic herniated discs are more calcified? No, absolutely not. Calcified thoracic herniated discs, thank God, are very, very, very rare. The vast majority of thoracic disc herniations are just like the one we did today, degenerated discs. They started out as an annular tear with a herniation, and then they became degenerated over years. And that's exactly what this patient had.
Next question comes from Ayus, once more on YouTube, asking, Doctor, what is the difference between the laser and a microdiscectomy surgery?
Oh, Ayus, what's the difference between a laser and microdiscectomy? Microdiscectomy, the surgeon is cutting you open. They're ripping the muscles off your spine and killing your muscles, so there's scar tissue and bleeding. You don't have that with the laser surgery. Then the surgeon is drilling a hole in your spine. To do a microdiscectomy, you must take this bone out right here. That's called a lamina. You must take that bone out. That's called a facet. They're going to take your lamina and facet and take it out. Either drill it or bite it with rongeurs. They're removing the bone. With the laser surgery, we come from the side. We don't take any bone or ligaments out of your spine. You don't want bone taken out of your spine. You need that bone. It holds your spine together. The doctors do it because they don't know any better. They don't think there's any other way to get there. They don't know how to come from the foramen like we do. They've never been trained. They don't even know it exists. They have no clue. So they're taking the bone out. You're getting your microdiscectomy. They're not doing an annular debridement like we do. You need the annular debridement for the annulus to heal. And then finally, you're going to come back after microdiscectomy for more surgery. You don't come back after Deuk laser disc repair for more surgery. Not surgery at the disc we fixed.
Next question comes from Yin Yang Yu, once more on YouTube, asking, how many thoracic surgeries have you done?
Well, Yin Yang Yu, you're asking how many thoracic spine surgeries I've done. Remember, I'm not a thoracic surgeon. Thoracic surgeons are surgeons that do surgery within the thoracic cavity. So they do surgery on your heart, your lungs, they take tumors out. I'm just a spine surgeon, so I'm a thoracic spine surgeon. And how many spine surgeries have I done in the thoracic spine? In my career, probably 100. How many have I done with the laser endoscopically? 25. The other 75 I did with mostly trauma patients from car accidents that had fracture dislocations or burst fractures, and we would do reconstructive surgery with fusions and all kinds of stuff, putting in cages, taking out bone, reconstructing the spine, stabilizing the spine with long segment screws and rods. Basically, the majority of my thoracic spine surgery has been open and invasive, and mostly in the first 10 years of my practice. And since then, I've moved away from trauma, and I do almost exclusively degenerative spine, and that's why I do just the Deuk laser disc repair for the disc problems and also facet joint problems.
Next question comes from Ali, once more on Facebook,
Hello, Allie.
asking which thoracic levels won't you do, and if there is not much thoracic disc left, is the foramen large enough to not irritate the nerve, or would there eventually be bony overgrowth pinching in?
Allie, great question. So first of all, which is the hardest thoracic levels to do? That's definitely up at the top, probably T1, T2, T2, T3, T3, T4. Those first three discs, very hard to do, the hardest. The thoracic surgery gets a little easier if you come down below T4, down to about T7, and then from below T7 to T12 is the easiest. Of course, easy is a relative term, right? You know, what happens, it doesn't matter that there's no disc left. You don't need disc. What matters is that that disc is causing pain. And what I do is I go in, I'm not looking for disc, I'm looking for a tear in the back of the disc. And it's that tear, called the posterior annular tear, where all the pain is coming from. Specifically, there's inflammatory tissue in the tear. That's my target. I'm not removing disc from your thoracic discs. I'm only debriding the annular tear. And no, it's never a situation where it's too narrow in the foramen, where the nerve comes out, that the nerves are getting pinched and stay pinched. I've never had that happen.
And last question, last but not least, comes from Yin Yang Yu, once more on YouTube, asking, do any levels create weakness in the shoulder?
Do any levels create weakness in the shoulder? Yes. If you have a weak shoulder, it could be due to any of the nerves coming out of your neck, C5, C6, C7, C8, or T1. They all go to the shoulder and past the shoulder and innervate muscles around the shoulder, girdle. So shoulder weakness can come from a pinched nerve at C4-5, C5-6, C6-7, C7-8, C7-T1, and even above that you can get weakness. So what matters though is get your MRI to us and let's do an MRI review so we can figure out what's wrong.
And that is it.
Well, I want to thank Henry for doing an amazing job with today's broadcast. We're done for the day. We'll be back Thursday. We have a few more surgeries Thursday. As a matter of fact, the thoracic case we just did here, this patient will have his 2 cervical discs done on Thursday. So he's here for the double whammy. Since he came from Buffalo down here, he wanted thoracic first and then cervical 2 days later. So he's a good example of somebody who's getting it all done and getting their life back, the quality of life back, because of our endoscopic laser surgery here at Deuk Spine. That said, I'll just give you a quick summary. Our next Netflix movie that we're trying to produce and then have streamed on Netflix, we're just almost done with writing the script. We're going to start filming soon. I could tell you the name of it is called Spine Scam. Spine Scam. And yeah, it'll be interesting. And then it's going to be a docudrama, hopefully. That's what we expect. And then we have the new website, which we've all been working very hard on. Some exciting news. We found a partner for our human chatbot, and that will be on our new website, that will be able to engage you and answer your questions, much like I do right now. The chatbot will be able to speak 42 different languages and will come in a variety of shapes and colors. So it's going to be exciting. We'll have multiple instances where they can be talking to multiple people at the same time, and they're going to draw on our new animations that we're creating, that I've been working on for almost a year now, and using those animations to teach people about annular tears, herniated discs, inflammation, and how to fix it. So we have a new website called Deuk Joint Institute, The Deuk Joint Institute is our sister company that treats hips, knees, shoulders. So if you know somebody with arthritis in their hip, their knee, their shoulder, you can come in, or their facet joints. This company will be treating them. We have a new website coming up. Come on in.
I think somebody like grazed the door.
All right. Well, I think that's it. Henry, I appreciate your time. Have
Thank
a
you.
wonderful afternoon, and we'll see you all